Recording in progress.
All right, well, good afternoon, everyone, and welcome to our 21st Century Caregiver Subcommittee meeting. I always forget that name. I always get confused between the Aging in Place Working Group, Caregiver Workforce Issues Subcommittee, or Subgroup, I guess is the official term of it. So welcome to our subgroup meeting. I just want to tell all of you how grateful I am for all of your input and feedback and for just overall being a part of this effort. I'm really pleased with the way things are coming together and very much appreciate your perspectives, your insights, your experiences, backgrounds, skill sets that you've all brought to the table to help inform our work and inform our recommendations. So I just wanted to start the meeting off with that to let you know how much I think you all rock, and I am grateful that each and every one of you raised your hand to be a part of this group and part of this effort. And I'm very hopeful about the impacts that we're going to have on our state of Delaware and on our caregivers, both the paid and unpaid caregiver workforces out there, the impacts that we're going to have on them now as well as in the future with our recommendations. So well done getting to this point, and thank you very much. So I guess we've got to start our meeting with a review of our meeting minutes from our last meeting, which is February 9th. So you all should have received those minutes from Will, and thank you very much, Will. And I should say as well, as I'm giving out and expressing my gratitude and giving my thanks, that Will is included in that as well. Will, thank you for all that you've done to coordinate us, keep us on task, just overall your amazing support and leadership with this group. We appreciate you very much. Certainly couldn't have gotten to this point without you. And we are grateful for all that you've done to help move this work forward.
Thank you.
Kudos to, I want to say just kudos to both of you all. We've really appreciated, Will, you making the process so easy to get connected and kind of keep track of us. And then Katie, to you for leading the group, because I think you've been just a tremendous asset and kind of keeping us focused. And Senator Benitez not on the call, but keeping him focused. I know he'd be the first to say that, right? So we really appreciate your leadership.
Oh, thank you, Berna. That means a lot. Thank you. So the minutes from February 9th, you all should have received those from Will. Are there any questions or changes that we need to make? If not, if I could have a motion to approve those minutes.
So moved.
Thank you, Wendell. In a second. Thank you, Bob. And I guess I all in support. Raise your hands. Any opposed? It doesn't look like it. Okay, awesome. Well, then moving along. And this is really the meat, I think, in the heart of our work is now getting down to the core of our recommendation. So putting pen to paper and what it is that we want to put forth to the larger Aging in Place working group. So Will did a really great job of synthesizing all of the information that we've covered in previous meetings that have been submitted by subgroup members. So you all should have received that as well ahead of this meeting. And I'm going to bring it up myself here. I think I may have deleted that window. I had myself all set and ready to go. Oh no, there it is. Okay. So, as Will outlined here, we really have as a subgroup identified three main themes for our recommendations. Those three main themes, really kind of revolve around strengthening the healthcare workforce, looking at how we can minimize shortages and create incentives and career pathways to recruit and retain professionals in all levels of care across the care continuum. We've also been looking at how we can establish or strengthen programs that provide support to informal caregivers, as well as what we can do to bolster awareness of the services that are currently out there in support of our informal caregivers. So again, Will has done a really great job of synthesizing this down to like those three bucketed areas that we as a subcommittee have discussed. The first one being development of a comprehensive recruitment and retention strategy for professional caregivers. And he's outlined some potential elements that we can include within this recommendation. Oh, great. Thank you, Will. Some of those ways that we could take a look at achieving this could be through evaluation of state funding, the reimbursement rates for service providers to retain existing professional caregivers and build a foundation for future recruitment expansion, enhancement or creation of a pipeline for career development, such as through partnership with educational institutions to promote programs, reviewing existing regulations to balance employer flexibility and accountability, and streamlining the education credential processes. And then as far as the informal caregiver network goes, we've been looking at, some recommendations related to a means of boosting awareness for issues and services related to caregiving. So this could include a PR campaign targeting caregiver awareness and support, improved media presence, both in digital and analog formats through revamping of existing offerings and exploration of new platforms, and consistent messaging and active spread of information to relevant individuals. And then finally, looking at bolstering family caregiver support. So this might include development of more formalized networks of family caregivers, expanding training opportunities and coordination with state and nonprofits, and our creation of a statewide caregiving strategy. So now I really wanted to, open it up to all of you, because you all have been so phenomenal throughout this process in giving your input, perspectives, expertise into what it is, what are the areas that we really want to hone in on and focus on and prioritize within our recommendations. But now that we're at the point of putting pen to paper, I would love to hear your thoughts on now the specifics, what it is, what levers do we want to use within state government to achieve these recommendations? So, and I guess we could start perhaps with the first bucket. It's a big one, is around the comprehensive retention and recruitment strategy for professional caregivers. And I know that this is a huge, huge issue for our state.
And I'll just say, what I'll do is I'll leave this up on the screen, and then I'll be jotting language down based on the conversations, and then that can hopefully be used to actually, for the final deliverable. So I'll just be taking notes as the discussion unfolds.
Great, thank you, Al. So, and I guess too, I look to our providers, here. I mean, we've talked a lot about reimbursement rates. So if there were something that we would be looking to put forth related to reimbursement rates, I would look to all of you and your expertise on how we would want to frame that, and specifically what we would be asking for. And then I also want to make sure too that, because I know that there's a lot of other groups out there who are also looking at this workforce shortage issue. And so I want to see if there's areas of alignment in terms of our messaging that we would be, promoting and advocating for the same or along the same things that other groups who are, similar, such as like the Home Care Association, for example. I know, Bob, you've brought them up before. So again, I certainly look to the providers and your expertise in this area of, the specifics that we might be wanting to put forth related to our recommendations for professional caregivers.
Well, I just might mention that, I believe, and I didn't attend this, but a couple of days ago, we had 20-some members of the Home Care Association presenting testimonials to the Joint Finance Committee in a period of several hours, talking about compensation rates, the fact that a lot of these rates had been unchanged for a number of years, despite the fact that other costs had been increasing, as we all know, at a very rapid rate. And I know there was a lot of receptive response from members of the committee, and I would suggest that that we contact, or you can contact Rob Lattin, who heads up the PR. I actually had Rob call Senator Bonini I said I would follow up on that, and I know he tried to get in touch, but I gather the senator was too busy to get back to him. But it might make sense to climb into the canoe with these folks because that bus has left the station. I mean, we're still trying to stand in line and get a ticket, and that bus is already pulled out. So we ought to figure out how to get on there as well, in my view.
Okay, yeah, Bob, if you could make that warm introduction for me to Rob, or even pass along his contact information, that would be great, and I'd be happy to reach out.
No problem. I'll take care of that and coordinate it. Not to worry.
Yeah, Katie and Bob, I talked to Rob as well, and he said, he does want to, obviously Senator Bonini is probably his cup overfloweth, but, he did try to reach out, and he would love to be able to talk about some of the points we've been working on as far as home care. I know I was at the JFC meeting as well, and I think that we had a pretty big impact. I know we had some statistics, and one of the ones when I spoke, just to let them know about reimbursement rates. Basically, what we're getting right now, it's not everyone, the data's not on everyone, but it's an average of about 82% of that money's gone directly to care. So that doesn't leave much operational cost when you get anything back. That's what, 18%. So, we do have some statistics on that and everything. I know that we had some really good families that spoke at that meeting. And this kind of goes down, I guess, to the second bullet on PR campaigns. And I actually spoke with the head of some of the media at Beata, and one of the people that spoke, and I don't know, many of you might have known that the father, I believe, was a football coach at Wesley and then at Dover, but their son got in an accident, like, I don't know how many years ago, but he's basically, unable to communicate. But anyhow, it had a huge impact. And I think it was the News Journal, one of the news medias already had got in touch with them. We got in touch and had a meeting and met with them, and they're going to start bringing this out. So there is going to be some media, information going out about this family. And, she's very proactive, not blaming caregivers, not blaming agencies, but, what the impact is to them. And I think that's going to be a huge message that we have going forward, but we don't have any dates on anything yet. So that's going to be something, I can try to keep you updated as well when we get more defined information on the rollout.
Okay.
Yeah, this is part of, are you okay if I actually forward our link to Nancy Rinaldi with Easter Seal so she can join us in the conversation?
Yeah,
Because
absolutely.
she's been kind of listening in the background, and I'd love to have her, especially when we get to some of the family caregiver support stuff. I'd love to have her be part of the conversation. But you're absolutely right. And this is part of that larger picture that really that evaluation of rates that has to take place across the spectrum, because it really goes through multiple divisions, multiple types of human services, and it's part of what needs to occur if we expect the nonprofit if we expect that the state's not going to be the entity to deliver all these services, right? that they're going to be contracting with organizations to provide those services. So I think part of what we would want to capture in that, Katie, is that it's not just an evaluation, it's an ongoing evaluation, and I don't know how we want exact wording, but it's not just a one and done. In other words, this has to be something that's built into the system so that there is regular and periodic evaluation of what's the cost to provide the service, and then what reimbursement rates are needed to meet that cost. Because now it's just I would describe it as you have a crisis, and you have to you beg for money, and then they throw some money at it, and then you move on to the next crisis, and that just is not a functional way to support the service structure.
Well, part of our problem is that we haven't been throwing money at it. And
Exactly.
one of the recommendations that we had, and this is like 5 years ago, was exactly this, and nothing has happened. I mean, there's a lot of talk, and we're talking, but there's been no action.
Yeah, I think that, Vernon, just what you said, I think the pivotal point here and something we do, it really is, it's ongoing. This can't be a one and done. And we really haven't focused or mentioned that a lot. Like we're saying, yeah, we need the reimbursement rates. And Bob, like you're saying, or anybody, yeah, well, here's 15% this year. That's not going to help us because this needs to be a constant evaluation of our efforts because the system broke. Like you said, Bob, 5 years ago, we did it. Nobody followed up. The system broke. And now we're in a crisis and now people are gone unattended and we don't know how to, to climb back up out of this hole is going to take effort on many, many, many fronts.
This is Cheryl. I just wanted to bring up a couple of things. If you haven't seen what was released just yesterday, DMMA's enhanced home and community-based Fmap stakeholder update, what they got from the feds. There are some encouraging numbers in there. Of course, it's not for everybody. It would be only for those for whom DMMA is connected to in terms of funding for, anybody that's home and community based. That does not at this point, include anybody in a facility unless there's very, very special circumstances. So,
Cheryl, are you sure that's not just for the state facility?
It doesn't look that way. If you read it really carefully, it looks like it's for home and community-based providers, anybody who is considered a home and community-based provider. But there's a lot to it, Vernon, to be honest with you. There's a lot of to be determined, I think, in that plan, including rate studies. And it does mention, the McNesby, and it references that as kind of a model for how they should be looking at other rate studies and for other groups.
Are you talking about what came out of the enhanced Fmap? Okay. I was talking about something else. Okay. I was talking about what the governor released yesterday. You're talking about what Steve Roth and DMMA released yesterday.
So again, that's not for everybody. That's not going to help people who are caregiving.
And that's part of the problem, right? Mm-hmm. We shouldn't it shouldn't be piecemeal. Like there needs to be this.
What's happened so far is it's all been piecemeal. So you have people who are getting, a area like there was money that was given to private duty nursing. All this is deserved. None of this, don't take me wrong. All this is deserved. Okay. Everybody is deserving of this. But when you give money in one direction, it squeezes the balloon over here, denying another group over here and of the services because people will follow the money. Our biggest problem, we can have money right now when we're recovering from a pandemic and there's money available. That money isn't going to last forever. So unless there's a way that the state's going to commit to continually putting this at the bottom of their budget every year, that's going to be a challenge. And also our biggest problem is there is nobody to do the jobs. There is a limited number of people, whether they're family caregivers that are caring for individuals at home, who I've done, you've done, a lot of people on this call have done, or when we need to find somebody to help us professionally. There's a limited number of people available in our state who are either interested in that work or qualified and can pass a background check, who are willing to work in this field. I think our biggest problem, I think the money is something we can deal with in a greater way. Like instead of giving this much over here and this much over here to this group, they need to be looking at it as a whole. And I think DMMA tried to do that with what's in that document, is try to not, rob Peter to pay Paul, basically. But the other issues that I've got in there is there's nothing in there about how to get more people interested in the field, how to get more people trained or qualified, or, through the rigorous program of licensing, certification, background check. That's part of our problem right there. And it's not the same in a family environment. Your family can care for you or they can't, depending upon their circumstances. They don't have the same rules and regulations that apply to that. But in the professional workforce, I don't know where these people are supposed to come from. And unless we do something about that, we're going to continue to be having the same conversation that we've been having here and that you and I have been having in Legislative Hall for a very long time. So I'm not sure what we can do other than to continue to point that out, that they're missing part of the problem. We need to find a way to be able to support the families that are not going to be getting Medicare, Medicaid benefits. And we also need to find a way to get more people interested in the field.
So Wendell, go ahead, and then I have a comment to that too, Cheryl. Thank you so much.
Yeah,
Go
just to
ahead,
follow,
Wendell.
basically just to follow up there, I think she hit the nail on the head. As we've discussed in these many meetings, the one thing it's missing is the people, the workers. And this is where, you know, you can throw all the money in the world to it, but if you don't have people interested that you know, and or what at whatever, I just don't see what I've been reading for the last several weeks and the information that was sent to us from the other states and that we received from Will just a couple weeks ago. But everybody's experiencing the same thing. The workforce is depleted. And I don't know how we're going to address that. And I don't think this meeting or 1,000 of these meetings will ever address that issue because we got to do something to entice people to step forward and want to get into the healthcare business. After all, and then of course, COVID didn't help us at all. So anyhow, I just wanted to echo those comments.
Well, we can make a difference with an increase in pay. I mean, that evidence, those numbers are pretty apparent. The problem or the challenge is that the system, and a lot of this money flows through Medicaid and is administered through managed care, which means insurance companies are involved. And the insurance company, I mean, their basic mantra is to deny and delay and to squeeze as much as they can in terms of wages. The other reality is that when you look, and I don't have these numbers in front of me, but if we look at the pie and we say, well, how much money does the state spend on Medicaid? Well, it's a lot, even though the feds, you know, chip in half of it, it's still a major part of the budget. And if you increase part of that budget by just, let's say 10%, that you're going to increase wages 10%, you're dealing with a huge delta in terms of the overall cost of the state. And that's what happens when you get to in front of the numbers people. They look at the thing and they say, uh-oh, this is going to be a huge hit on the bottom line, and I'm not willing to stick my neck out to support that. And we've made a lot of progress in terms of bringing the attention to it because the social impact, the personal impact of people, not only the workers, but people that they serve. And I happen to know that a number of providers have waiting lists. I mean, they just don't have the people to provide the work. It's just not there. But I do know that that Home Instead has significantly increased wages. And we've done that just in order to hold on to a major portion of the census, the worker census that we have. But there have been a huge number of, a huge amount of pressure in terms of the limited resource here. And the fact that the resource is underpaid and the fact that the need keeps growing. And so at the end of the day, I think we have to come together in some fashion so that we have a critical mass of supporters to actually make something happen. Because as long as we've got fragmented efforts, like the Delaware Home Care Association, you know, having meetings down in Dover, and Jackie's been big part of that. And we've got other providers and other influencers, but nothing's coordinated. And so there's no critical mass of support that is in my view needed in order to move the needle on this stuff. So
Yeah.
Bob,
Yeah,
that's what's worked in the past is your individual groups have all, gone after their members of the General Assembly and made their case, and it's worked. I mean, I've done it, Vern's done it, we've all done it over the years. It's what's worked. But what's happened is, and I have some statistics I'll share with Katie. These come from the Bureau of Labor Statistics in Delaware. When the money that came to increase the home health care wages went up, you actually got more people qualified as home health care. They're the only job category in Delaware that went up during the pandemic. Everybody else lost in nursing homes significantly, but it didn't mean that you could find enough people for a home instead. It just means a whole bunch of people decided, I'm going to start a home care company. And so you got more companies who are trying to compete for that same pot of people who are interested in becoming a home health care worker. So rather than, the only solution to that is just saying, okay, we can only have this many home care companies and stop accepting new licenses for a while until we figure out how to fully staff the ones we have, like they do or try to do with the Healthcare Resources Board, which, is not necessarily 100% effective. But I'm just telling you, the numbers don't lie. The number of home health care workers increased because of that increase in support. But it doesn't mean that you don't have a heck of a time trying to find people to fill those jobs because it diluted the workforce. Hospitals decreased and they came up a tiny bit. Ambulatory services decreased a lot and then came back up. But nursing homes, assisted living is still very much lower than they were during the pandemic. It's starting to up a little bit, increase a little bit because people feel more comfortable now. That the pandemic seems to be, waning, or at least we're learning to live with it. But we still have a supply problem. And we also have the burnout problem from the people who have stuck in there and worked in all of our environments: home care, hospitals, group homes, nursing homes, assisted livings, schools. Anybody with that healthcare background that has worked through this thing is exhausted mentally and physically. And, if they're close to retirement, they're getting the heck out of here. So we're losing that group as well. So we have a supply problem, significant supply problem. And I'm not sure I wish I had a solution to that. But I really think we need, in our recommendations, we need to push heavily on the fact that I'm not sure that there's a consistent approach to that in the training and in the recruitment and the whatever we can do to get investment put into that piece of it, get people to take a look at all the regs and regulations and the barriers to employment and education. What can be done? And not just, the state spent years and years and years and a lot of money to be able to change the primary care system to try to get more doctors to stay as primary care. It took years. They're still working on it. And that's one little tiny piece of healthcare. So,
and I can just add to Cheryl's point. There are a lot of people that have, have gone off the radar screen because they're working as independent contractors. They're basically, taking a shortcut through the system, advertising on the web and getting paid directly to do the work. And therefore, thereby avoiding any licensure or quality requirements, and basically able to work off the books and keep all of the compensation. So,
yeah, but that sacrifices quality.
Well,
of course,
families don't realize necessarily that person isn't certified or background checked or doesn't have an adult abuse issue. They don't know that. And the worker doesn't realize that the person that hired them in that quote unquote staffing agency isn't withholding their taxes, isn't covering them for workers' compensation issues.
A lot of them don't care as well. Some of them know, because I've been fighting this one for years and years. There is a segment of the population that just says, hey, look at, I understand that they're working off the books, but I can't afford the wages that or the cost of licensed care, and so I'm going to go this route, and there's always going to be that element. So, but you're absolutely right, Cheryl, that it's pretty much of an unregulated open field in terms of quality.
Well, and I think there's also people that need to be educated on the fact if you go to work for one of these places, I'm talking about the staffing agencies now, that the worker needs to know, find out, are you an independent contractor or are you an employee? Because if you're an independent contractor, when it comes to tax time, nobody's been withholding your taxes.
Yep.
Money, you're gonna have to pay that bill yourself, or they're not covering your workers' compensation. They're not covering you for your professional licenses. Any of that is not being covered if you're an independent contractor. And a lot of these people may or may not be sophisticated enough to realize that.
A lot of the income is below the line where they would need to pay any income taxes anyway. But you're absolutely right that they're not. They may be aware and don't care, but many of them just simply aren't aware.
Brenna, I think I heard you piping in there.
Well, no, I was going to come back to you because I guess I want to understand a little more too, like what do you need from us, and how much more specific we've had this. I mean, everything that we've just talked about has been so on point. It's sort of how do we focus that down for your purposes?
Yeah, right. So that's what I've been sitting here thinking about, right? We need to really hone it down, I think, to something specific that we want to, again, put forth. I tend to go, the workforce issue, it's huge and it's broad and there's a lot of pieces to it. So we're not going to solve all of those pieces, right, as a subgroup here with our recommendations. But even if we could, like I've heard someone refer to it as hemorrhaging, right? But if we could put 1-2 Band-Aids on that, it's not going to heal the wound automatically, but it's at least going to do something and start to make a difference. And then combined with these other efforts that are out there, all of that together is going to help address this issue. But I do think we need to be thinking about like those specific, like what is it specifically that we want our policymakers to do to address this issue? With tangible, specific recommendations, that's sort of the direction I've been leaning, and talks with Senator Bonini, he's been leaning that same way too, so that we can, present these to the General Assembly, for example, and the specific things that they can act upon. So I think, I'm hearing you say around like increasing reimbursement rate, but also the importance of this ongoing evaluation. So, I certainly can work with Will and the team and Senator Bonini, and how we want to the verbiage around that, like exactly how we want to package that and present that recommendation. Okay. I think around
just to that, just to I may have mentioned before, DHSS has been charged with doing, it's called the rate methodology roadmap, and they've been charged with looking at least across all of DHSS, what are the rates, reimbursement rates that are paid, and they're supposed to be evaluating and putting forward a system where there is a regular review of and prioritization of the rate increases. And I think it's just languished a lot because of the pandemic, but when this was put into epilogue language, and I was just actually trying to find it on the website, it was back in 2020. The intent was to try to have a broader view. So it's not just, one group against the other and fighting over, pennies. It's intended to be, we shouldn't have to go down there begging at Lake Hall every year. It should be a regular part of the process that the department is undertaking. So one of the things that I think we could do is go back to that and just really enforce again upon them that this should be something that they should be actively involved in doing. And I can send you there's gobs of information, but I can send you the link that we can reference if that would be helpful, Katie.
Yeah, that would be great, Brenna. Thank you.
Because Bob, that gets us exactly what you were saying, because we do have to, we have to join together. We can't, our sectors are overlapping, and we can't, the services are broad, but we've got to come together as a larger coalition to make those kind of changes.
Right. And we need a number.
Happen.
I think we ought to have a number. I think we ought to have something. It's to say, well, we should pay them more. No, let's come up with a number that can stand up. 10% more, 15% more, 12. I mean, it'll be a point of arguing, but I think we need something reasonably concrete, and we ought to focus. What happens is that you get a whole bunch of stuff that and then nothing happens. But if you have one war cry, one rallying point, then you have at least an opportunity. Even if you don't get that, you at least get some dialogue and some conversation going. So I just, when I'm looking down and I'm seeing 5 years plus have lapsed since the same recommendations were made and nothing happened. Maybe we ought to just get a number. Is it 10% more? 15%?
We've talked in our association, Bob, about the need for a constitutional amendment to the state constitution to take that kind of a broad outlook, look at what, how human services are going to be provided in the state, and to assure that it's going to be something that's going to be addressed, as opposed to this, well, when they have a little bit of money, then maybe some of this will be addressed. And maybe it won't, because sometimes they've had money and it still hasn't been addressed, right?
Well, boiling the ocean scares me. As soon as we get into something really that broad, I just, my life experience suggests that, you make it really difficult to happen. So you were better off, in my view, and of course, this is a committee, so everybody has input on this, but to have something concrete, a war cry that we say, we've looked at this, and when you strip away all of the gobbledygook that goes with these recommendations, we believe that these workers require, and I'll make this number up, a 15% wage increase, and that the evidence is that will provide a larger pool of talent to draw from. It'll also make a big difference in terms of life quality for these individuals, et cetera. But I think that if you have something, then they can argue, say, well, I don't think it should be 15%, it should be 12. Then we're into, and that's fine, as long as we've planted a stake in the ground and are rallying around something. But when we get so diffuse in terms of our recommendations, we end up, basically with a lot of things that sound good, and we fill up paper with a lot of words, but nothing happens.
Yeah, so I think, right, and that's why I really love to see this group come together with those concrete, specific recommendations, like the how, what we want to happen in terms of policy change, what we exactly we want to see, and what we're asking for, as opposed to all that like verbose language that's pretty general and broad. Like we need more, we've got a healthcare workforce shortage. We need more healthcare workers. We need to recruit, retain. That's great. That's what we want to do. But how do we want to do it? What change do we want to happen? So I know I can't believe that it's already almost 10:04 and we only have till 4 o'clock with this group. So I want to make sure that we get into these other pieces of our recommendations. I would like to schedule another meeting of this subgroup before we meet again with the larger Aging in Place working group, which is meeting on April 8th. So I'm going to get together with Senator Bonini and see what his availability looks like, because I'd really like for him to be a part of this conversation as we, again, really hone in on the specifics that we want to put forth and present to the larger working group. The only other thing that I just wanted to bring up here related to, because this was something that a couple of you brought up, ensuring that we have a strong pipeline of people interested in this type of work. And so I did talk with a colleague of mine in Wisconsin. Wisconsin has a program, they call it the Wiz Caregiver Careers. It's funded through the state, and it's a workforce development program designed to address the direct care workforce shortage in Wisconsin. So it provides free training, free certification testing, and a $500 sign-on bonus or retention bonus to direct care workers. And it also seeks to encourage new workers to enter the field by lowering costs. There's a public awareness campaign about it, and it makes training more readily accessible. So that was something else I thought maybe we want to take a look at. I'd have to figure out how exactly want to package that recommendation. But again, this was something that the state has appropriated within Wisconsin. And from what my colleagues said, it's been pretty popular, and they've had, I think, close to 5,000 direct care workers go through this program. So I see, Cheryl, you have a hand raised. I'd love your thoughts on that.
Yeah, not so much about that program, but I had a question for something that is, can you hear me okay?
Yes, we can.
Verna and Bob, when you hire somebody new, how do they get their background check done?
I mean, they have to go, it depends on what they're being hired for.
They get fingerprinted by the state police.
Do they have to drive to Dover to get that done?
You bet.
Mm-hmm. So
they can do it at a place in each county.
There's a place in each county, but if let's say you're starting something at a CNA or a, direct support professional, it's $16 an hour or something like that, $17 an hour, whatever it is. Now I'm looking at my numbers, it's $19 an hour to start. So that person has to drive, if you live in Newcastle County, you have to drive to Dover to do a walk-in background check to get fingerprinted.
Yep. And
so if you're somebody that does not have a car, maybe using public transportation, or you have children,
they have to make a doctor's appointment and get a tuberculin test.
Mm-hmm. Yep, 2 of those, but you can do them in each county, but you have to wait maybe 2 or 3 weeks to get an appointment in each county. The only place you can do a walk-in is Dover.
It's burdensome, yes.
And that, I think, is an unfair obstacle, particularly to low-wage earners in this field. They should have to have some other way to be able to get their fingerprinting done. And if they have to do through state police, because that's the way it's written, then that's fine. But they have to be able to have an ability to go to someplace, somewhere in each county without having to drive to Dover on certain hours, 1 day a week, or however many days a week that they're open, and to be able to get it done. They'll go work somewhere else.
Yep, we've been fighting this. Yeah, we've been fighting this with the regulatory people, with Corinna and her crew, as well as the state police. I mean, and we have not been able to budge them. But the association has brought this to their attention, and you're absolutely right, Cheryl. I mean, it is very burdensome.
Think it's discriminatory? I think it's discriminatory.
Of course.
Certainly discouraging. And it is different for different programs and different divisions. But in some, I think the cost is covered. I think we cover the cost, but I don't know if we do that up front or if they have to pay up front for it. Ironically, I will tell you all, I just had to go yesterday to get fingerprinted in order to be qualified as a caregiver for my daughter. And to access some of the respite dollars that she has access to.
My point is, you have transportation, you know where to go.
Exactly. Exactly. I paid the $65.
And facilities will cover the cost of getting it done. It's getting somebody who doesn't have a car, who would have to struggle to get someone to watch their children, get them to Dover, or you'll lose them to somebody else. And I can guarantee you that is where a lot of people are in the home health care and in long-term care When people are just getting started, they're just getting their first jobs, we're losing them to that particular barrier, which to me feels like it's discriminatory against those people who do not have that capability. And if there was a walk-in center in each place, I know the state police don't want to hear this, but there needs to be a better way to manage this.
Yep.
And
Well said.
you make an appointment 2 or 3 weeks later, that person's already got another job somewhere else. It used to be that they could do the fingerprinting in the buildings, send it to the state police, and make sure the person was, not Jack the Ripper. But I know we don't want to wait for that because that takes longer. You don't want somebody working in a building or working with your mother or father who hasn't had that approved yet. So, but other states do it differently. They don't make people go through all this.
Thank you, Cheryl.
Katie, I liked your idea that you had from the other state. I did like that idea. I didn't want to throw cold water on it, but I wanted to make sure I gave you something very concrete to see if there's any way to be able to figure it out.
Yeah, thank you. I appreciate that. So again, I know we're getting super close to 4 o'clock, and we haven't gotten into the caregiver, the informal caregiver side of things, which is, of course, a big part of all of this and our efforts. And, they are a big part of ensuring that we're supporting our neighbors in terms of aging in place in their communities of choice. And, this is also a piece of the pie related to the workforce shortage as well, because informal caregivers, provide a lion's share or a good portion of care that's provided to Delawareans who need it. So I want to make sure we spend a couple of minutes here just diving a little deeper into the recommendations related to our informal caregivers. Again, I know this is a pretty big conversation and a lot to talk about. So we are going to have that next meeting before the next Aging in Place working group meeting. So perhaps I think what I'll do is I'll start with the caregiving piece there. But I'd love some initial thoughts on specifics. I mean, we've talked a lot as part of this group about the need to increase awareness of services for caregivers. So, perhaps that's one of the recommendations we want to focus on is funding campaigns that'll target caregiver awareness and support. I also know that, right now an individual may not identify themselves as a caregiver, but a couple of years from now, they may find themselves in that caregiver role. And so public awareness campaign funded now might not necessarily resonate with that person in the future. But it certainly is something or one of the tactics we might want to look at in terms of increasing awareness to caregivers of resources and services that are already available. But again, I'll throw it out to the group for your thoughts. I'd love some thoughts.
I think it also depends on what the methodology is for creating that awareness too, because if it's instituting certain practices that become part of whether it's the physician's visits or the discharge, plans for people, then that becomes an ongoing practice, right?
I like that's a great point, Verna.
Wendell, I think you mentioned even something is based by something like the realtors or right. And I know I don't know if Nancy Rinaldi was able to jump on or not, but I know she's talked about libraries. That the collaborating with the libraries, and especially now, like they've just gotten a boatload of ARPA money and they're upgrading, and we're getting better bandwidth, and so other hubs like that though could be, and that's like again that is building it into the process already. So it's not just splashing with a media campaign. It's built into the system. Nancy's talked about trying to do some regular visiting. She does do regular visits at libraries to be there so that people would know, okay, we have the caregiver resources available here every Tuesday of the month or whatever. And that's just a very small thing.
Mm-hmm. Yeah, Good, great points, Verna. Thank you. Cheryl, I see your hand raised.
I was wondering whether or not we had an opportunity as a part of, I don't know if there's anybody on this subcommittee that's connected to the hospitals, but we may want to see if we can, and if there is, I apologize if I've missed you, but the discharge planners and the social workers in the hospitals.
We looked into that. We had a recommendation to do that back about 5 years ago, and we didn't get that far. They just don't want to take it on, the responsibilities, their legal issues, it's the time involved. But the concept of, providing some training prior to discharge for family members of someone that's coming home that needs additional help makes total sense, because people don't know what to do. And but finding the right resource and getting a commitment in order to do it, we weren't successful in that.
Well, I think it's something we should be asking our hospital partners to take on, because I just spent a couple hours this morning and a couple hours yesterday and last night trying to solve a problem for a family who, they don't, for number one mistake they made was they didn't buy Medicare Part B because they didn't think they would need it. She was healthy, thought she'd never need it. It was another $150 a month. Never thought she'd need it. Now she needs it. She can't get it because she's past the enrollment time. So I think seniors need education as you get older. Now she's almost 80. Maybe that's the time to buy that extra, pay that extra premium, because you're more likely to need it the older you get for
It's
anything
case
outside of
management,
hospital.
right?
Some
Really
kind of,
case
maybe that's
management.
the insurance commissioner's office can be helpful in that education, that it would help with any, home care, other assisted issues, if they need to spend time, in any kind of a rehab or get home rehab. All those kinds of things are not Medicare Part A, that's hospital. So some kind of education. And then the discharge planner, who was in a big fat hurry to get him out of the hospital and then someplace else, didn't tell him it was only good for 20 days. So now this family is struggling. I don't have anybody, she's not ready to go home. She doesn't have any insurance past 20 days. We don't have anybody at home who can care for her. Her twin sister's also almost 80 years old. What do we do? So it's the kind of thing where I'm sure you all face this all the time, trying to solve a problem for a family that they're between a rock and a hard place. They don't qualify for Medicaid. They're going to be having to rely on home caregivers in some way, shape, or form. And there's not a whole lot of resources. So it's some of it was of their own making, just because of not getting that insurance, but some was also the hospital discharge planner should have at least given them a heads up. This is really only going to buy you 20 days. You need to be thinking ahead for what are you going to do after 20 days. So they had at least some time to plan. So I think we added to our wish list here. And whether or not these things actually happen, but we can certainly add it to the wish list, right?
And so many of those things are the things that are going to prevent the person from being back in the hospital within.
Right. And costing everybody more money and the person more aggravation and pain.
Mm-hmm. Right.
I know too, another group is currently looking at community navigators. I can't remember what subgroup it is, but I know that was one of the thoughts that they had presented to the Aging in Place Working Group as a potential recommendation, was around utilizing community organizations and really keeping it focused on being local in the community, but providing navigation for families. And I think that could be applicable to caregivers as well, in terms of navigating the services and supports and resources out there for caregivers. And I shared with Representative Briggs King, and I'll share with all of you too, that I came across some legislation that was introduced in California. Of course, I know California and Delaware are certainly not the same, and there's a lot of big differences between our two states. But in California, there might be some things that we could potentially replicate here in Delaware with what California is looking to do with their Community Navigator program. But it's a grant-funded program funded through the state, but grant funding for community organizations to incentivize community organizations to provide these navigation services. So that might be something as well that I don't know if you all want to take a look at that, but we certainly I can talk with that other subgroup and see if that's still something that they're taking a further look at prioritizing within the recommendations, but being the community navigator. And Wendell, go ahead.
I think we actually brought that up in our group, talking about having community, a group in Newcastle County, wanting, a group in each county that would help as volunteers to serve in this capacity. And that group would be, would have to receive some training, of course, and guidance. But I think that's a great idea. I think if you bring it local, someone was saying, Cheryl was saying earlier, I think no one's going to drive to Newcastle County to sit with a group of us or anybody, whoever it might be, to listen to us, because that's too far to drive. But if they're local and they can go to a library for a meeting, I think that's an excellent idea.
Yeah, awesome.
I think we talked a little. I think it was this idea that if there was a kind of like a grant program that then these community organizations make proposals and that could sort of be the umbrella under which the community navigators are operating, right? So, because you're right, you're exactly right, Wendell. You get those kind of the organizations that have their boots on the ground, that that are doing the outreach and know the community. Oftentimes, they're going to do the best job in actually reaching the folks who need the assistance in a much more personal way.
Mm-hmm.
And also,
it may be different for one community. Maybe it's going to be maybe different in the Hispanic community than what it's going to be in in other communities.
But I think your experience would teach that if people have a one-on-one, face to face, they're more open, will be more prone to open up to you. And I think it's a learning opportunity for us. I mean, whether it's this committee or the navigators, whoever it might be, to develop that information for the next time this goes around. But I think you listen to as we used to say in our business, the voice of the customer, and they are the customers, So I think we can all learn and be open-minded.
Mm-hmm. Yeah, great point, Wendell.
Yeah, Katie, you've done some work in terms of dementia care training for family members through the association. I mean, the Alzheimer's Association has done a lot of work in terms of educating family members on how to care for a loved one with cognitive disabilities. So you may have some experiences in that area that would be helpful to us.
Yeah, I mean, absolutely. We do. We have a lot of resources available to support families who are caring for a loved one with dementia, because education is key and it's powerful. And the more people are educated and informed and feeling confident and comfortable in providing care, armed with that training information, then, of course, it's going to support people in a better way to be able to age in place in their communities of choice. Cheryl, I see your hand up.
Just going to say, Verna, do you remember when we had the state innovation model grant money? Remember that big contest? This is a Bettina Rivera's year, and
Markel.
Right, there was a lot of money and a lot of effort written about that, and maybe it's something we could find and share with Katie somewhere. I'm trying to think where in the world of my records that would be, but and if you don't mind, Verna, sending me that information on the Medicaid rate study. I was looking for that myself. I couldn't find it the other day. There was, when the state had all that innovation fund model money, Katie, they had a whole workforce subsection of which I was on that group, and some of the community navigators and community health workers, I think they called them community health workers, were a big part of that proposal. And they weren't all volunteers. I think there was some suggestion that they would be people who would be at a certain level of training and experience, but they would be paid people. But it's something to maybe look at, because there was a lot of time and attention and effort and money that was spent on developing that model, and I'm not sure it actually went anywhere.
Yeah, that'd be really helpful. Thanks, Cheryl. I appreciate you sharing that information.
If we can try to find that, because it was a few years ago, but I don't think the idea is that different, honestly.
Yeah, thank you. That sounds helpful. So other thoughts on recommendations related to caregivers?
The only thing, Katie, this is Jackie. I mean, I think we're touching on it, but there's probably a way somehow too that we could look even partnering with home care agencies. If someone say gets out of hospital, you know, everybody's limited on resources and time, but under that, it might have to be an agency under the delegation of a nurse. I know you'll never get that to be oversight to actually happen for the person, but they could have somebody to actually train them to kind of wean them into taking care of the individual themselves. So you do have someone with a professional background that can, you know, kind of look and say, okay, whatever the care may be, turning them or bathing them or how to properly lift them, where agencies can maybe do. And there is groups on the transitional care, but kind of, again, this is a different kind of avenue you would take in a transitional care to the caregiver from coming from a facility or a hospital or otherwise.
Mm-hmm. Thanks, Jackie. Cheryl, I see your hand raised. Is that from before?
I think we'll probably need to come back to the caregiver topic.
I think so too. So Wendell, I see your hand raised as well.
Yes, just one thing, and I think we've kind of, maybe I'm missing it, but we talked about a centralized number where people could get help. And one thing that I learned from AARP just a couple of weeks ago after our last meeting, and I'm sure most of you are aware of it, I certainly wasn't, there's a number, dial 211. And you dial 211, and it actually, there's a live person, and they do not leave you to, and if you call and say, I need help with Alzheimer's, then, or whatever, they actually direct you, stay on the line with you, and take you to make sure that you're speaking to that person that you need help. And, you know, we had talked about, and maybe this was in the main group, but I think here, when we talk about our caregivers, one of the things we talked about was educating our own caregivers, such as myself, or all of us in this room, or on this panel, we've all been a caregiver to our family. And so, but I had no idea that existed. No one ever told me at the hospital upon discharge, or I've just never heard of it. I have not tested it yet, but I intend to. And I believe it goes through, Verna, you're shaking your head, but does it go through Red Cross?
It goes through DHSS, but I don't know which department.
Well, actually, this one goes through the what is it? Not the American Red Cross, the other United. I
think you're right. United Way, Delaware.
That's it, United Way. That's it. I think it's United Way. Thank you. And it's just something I think we probably want to keep, not maybe as a recommendation, certainly, but as something that we want to pass on. And remember Senator Bonini and both senators and Krista too, they all said, you know, we can make that happen just to educate more on our home caregivers situation. Doesn't, I mean, it applies to all of us, I guess, not just, you know, non-professionals like myself, but to everybody.
Mm-hmm.
Delaware 211, it's called.
Thank you. Thank you.
That's a great idea, Wendell. It's a great idea to let more people know about that.
Yeah. Honestly, I'd never heard of it. So I was kind of excited about it. So thank you.
Yeah, that's a great suggestion, Wendell. And it really is. I think that would be a good one-stop shop. So, I mean, I think about the Alzheimer's Association, we have our helpline, but not all caregivers are dementia caregivers, right? We have caregivers of that are caring for individuals who are impacted in a lot of different ways. And so having that one-stop shop where no matter who you're caring for, what information you need, you can still go to that one centralized place. But then I know with 211 and the Alzheimer's Association, if I am a dementia caregiver and I call 211, they have all your information and would be able to connect that caregiver to our helpline, for example.
Right. Well, I thought the good thing was at least you're not lost out in cyberspace somewhere on the web. You're speaking to a live body who will help you to navigate to get to that need.
Yeah, yeah, absolutely.
Thank you.
Thank you for bringing that up, Wendell. Well, I know that we are past time, so I appreciate you all hanging on here after 4 o'clock. That this, I think, is a really good place to start. This has been an incredibly helpful conversation to have with all of you. And so I think now, Will, we open it up for public comment?
Yes, if you would like to make public comment, please indicate so by raising your hand in Zoom. And no hands have raised. If you'd like to submit written public comment, please do so by sending it by email to william.lescas@delaware.gov. That's william.lescas@delaware.gov. Katie, I'll hand it back over to you.
Okay, great. Well, thank you all again for hanging on past 4 o'clock. I appreciate this robust conversation. And again, I'm incredibly grateful for your insights, perspectives, and expertise. I think that these recommendations are coming together. But I do think we will need one more meeting as a subgroup so that we have a good set of recommendations that we all feel comfortable with in terms of presenting those to the Aging in Place Working Group. So I'm going to reach out to Senator Bonini, see what his availability looks like in the coming weeks, and then we'll get a date out to you all as soon as possible so you can get it on your calendars as well. But with
Awesome.
that, it concludes our meeting.
Thank you, Katie.
Bye.
All right,
Have a
thank
good
you
one.
all. Have a great afternoon.
Recording
too.
stopped.